It's time for another 3-question warm-up. First question. A CT scan of the head shows a crescent-shaped lesion. What is the most likely cause of this lesion? This is a subdural hematoma, so the most likely cause is some kind of head trauma that causes tearing of the bridging veins. Those bridging veins are more vulnerable to tearing when you have cerebral atrophy, so you definitely want to think about subdural hematoma in your elderly or alcoholic patients. Next, what is the initial radiologic study in a patient with TIA or stroke symptoms? Well, first you have to figure out if this is a hemorrhagic stroke or if it's an ischemic stroke due to thromboembolism. And the way you do that is by getting a CT scan of the head without contrast. That'll tell you if there's a hemorrhage or not. And then what radiologic studies should be performed to evaluate the underlying cause of the TIA or stroke? If it's an ischemic stroke, you'll probably get an MRI to get a better picture of the actual damage to the brain tissue. But as far as determining the underlying cause, the tests you want to get are a carotid Doppler ultrasound to look for a plaque as the source of the thromboembolus, an echocardiogram to look for a mural thrombus, a patent foramen or valley, or any vegetations that might be on the valves. And you might also get an MR angiogram or a CT angiogram to look at the brain vasculature to identify the actual occluded artery. And the last question. A 2-year-old develops lethargy, hypoglycemia, and abnormal LFTs approximately 1 week after being seen for a febrile URI. What is the most likely diagnosis? This is Reye syndrome or hepatoencephalopathy. You want to think of this in a child with CNS problems and liver problems after having had some kind of febrile illness. Presumably his caregiver treated his fever with aspirin. So that's why you don't give aspirin to kids, with the one exception being for Kawasaki disease. All right, it's time for that lecture.
In this video, we're going to talk about bipolar disorder. Generally speaking, bipolar disorder is a mood disorder in which the individual experiences periods of severely depressed mood and periods of extremely elevated mood, which is called a manic episode. So they're fluctuating between these two poles on the opposite ends of the mood spectrum, depression and mania. So they're bipolar. Now we're going to talk about the features of mania or manic episodes in just a moment. But first I want to define the 2 main types of bipolar disorder. So take a look at number 4 in your study guide. Bipolar 1 disorder is where the patient has at least one manic episode. So they're not required to have the depression. They may or may not have major depressive episodes or hypomanic episodes, but they're not required to. Generally, these patients will have some depression eventually if they haven't already, but you don't have to see the depression to make the diagnosis of bipolar 1 disorder. Then bipolar 2 disorder requires at least one hypomanic episode plus at least one major depressive episode. So for bipolar 2, they do have to have both. And they can't have had a manic episode. If they've ever had a manic episode, that would make the diagnosis bipolar 1 disorder. So let's talk about mania and hypomania. They're pretty similar. The difference is in the severity and in the duration. A manic episode is defined as a distinct period of abnormally and persistently elevated, expansive, or irritable mood and abnormally and persistently increased goal-directed activity or energy. So it's not simply the opposite of depression, being super happy. Sometimes mania is happy mania, but sometimes it's more of an edgy, irritable mania. And as you know, the time course is often very important with psychiatric disorders. In a true manic episode, this period of elevated or irritable mood and increased energy has to last at least 1 week. Now, this may be disturbing to the patient, but sometimes patients like the way they feel during a manic episode because they feel so productive and they're having a lot of fun. Now, in your study guide, there's a mnemonic for the symptoms associated with the manic episodes, which is dig fast. It kind of sounds like increased activity or energy, right? D is for distractibility. I is for insomnia. And this is different from the insomnia we see with depression. With mania, this is more of a decreased need for sleep. These patients may only sleep a few hours a night during their manic episode for days at a time, but they can wake up feeling very full of energy. G is for grandiosity, which is an inflated sense of self-esteem. So they have self-confidence to spare. They think they're the most important, most talented, most intelligent person in the whole world. Or sometimes it's a delusional grandiosity where they think they're Jesus or they think they're the president. F is flight of ideas and racing thoughts. So they just can't slow down their brains. Their thoughts are going from one thing to the next with really no continuity. A is activity, especially that goal-directed activity, and also agitation. They might become super productive during the manic episode, and they do all their taxes, and they scrub all the baseboards at 3 a.m., and then they detail the car, and then they detail the neighbor's car. So they have energy to spare. But sometimes, instead of being productive, this energy just makes them agitated and antsy, and they just can't sit still. Or if they're one of those angry, irritable manics, they have all this extra energy, they might get riled up about some issue and stay up all night writing a letter to every member of Congress. S is for speech, so they have pressured speech. They're going to start answering questions before you finish asking the question. Kind of goes along with the flight of ideas. They just have all these ideas which are just flying out of their mouth. They tend to talk louder than normal as well. T is for taking risks. These individuals seek pleasure without regard for the consequences. So they might become sexually promiscuous during a manic episode, or they might start abusing drugs or alcohol, or they might blow up their boss and quit their job, or they might max out their credit cards buying junk on the home shopping channel. Then the next question asks, what are the differences between a manic episode and a hypomanic episode? So for a manic episode, you generally need to have at least 3 of these dig fast symptoms. The symptoms have to last at least 1 week, and they often last a couple of weeks, and the symptoms have to either cause impairment in social and occupational function, or be severe enough to require hospitalization, or include psychotic features. Then for hypomania, it's the same list of symptoms with the expansive or irritable mood, and you still need at least 3 dig fast symptoms, but you only need symptoms for 4 consecutive days, not for a whole week. And hypomania is less severe by definition, so the disturbance is not severe enough to cause impaired functioning or to require hospitalization, and there's no psychosis. So if you have psychotic features like hallucinations or delusions, that's going to be a manic episode. Impairment in social and occupational functioning means, can the patient hold down a job? Can he stay out of jail? Has his behavior alienated him from his spouse and from his family? So if the patient becomes so grandiose that he starts dressing like a superhero and going out in the middle of the night to fight crime and gets himself arrested and loses his job, that might be a manic episode because it's clearly interfering with social and occupational functioning. Or if he starts having grandiose delusions, he thinks he is a superhero and he starts hearing voices telling him to assemble at Avengers Tower, that's psychosis. So that's mania, not hypomania. So how do we treat bipolar disorder? Well, we treat bipolar 1 and bipolar 2 pretty much the same way. And technically there are different regimens for treating acute mania versus chronic maintenance therapy, but for the most part we use the same classes of drugs. The main pharmacological treatments for bipolar disorder are lithium, anticonvulsants like valproic acid or carbamazepine or lamotrigine, and atypical antipsychotics like aripiprazole, olanzapine, quetiapine, or risperidone. Sometimes we use the traditional antipsychotic haloperidol, but for the most part, think about atypical antipsychotics. Now, lithium and anticonvulsants are sometimes called mood stabilizers. And we often use one of these at first line, and then we add an atypical antipsychotic if the initial therapy isn't working, or if the manic episode is really severe to begin with. We might start with a combination of lithium plus an antipsychotic, or a combination of valproic acid plus an antipsychotic. And if the patient has renal failure, you might have to go to one of the anticonvulsants first because lithium is contraindicated in renal failure patients. We can also treat non-pharmacologically with electroconvulsive therapy, or ECT. Again, ECT works really well and fairly quickly, but it's usually used for refractory or difficult to treat mania. Now, what about the patient with a diagnosis of bipolar disorder who comes in acutely depressed? Do you just use an antidepressant like an SSRI? Well, think about it. If you start increasing serotonin, you start increasing norepinephrine, you run the risk of pushing that patient from depression into acute mania. So the first-line treatment for depression in bipolar disorder is still going to be a mood stabilizer, not an antidepressant. And when you're seeing a patient with depression, it's important to take a very good history to see if the patient's ever had an episode of mania or hypomania. Because if the patient has undiagnosed bipolar disorder and you treat them inappropriately with an SSRI, you could cause some trouble. Let's go back and talk about lithium for a moment, because lithium is the classic drug used for long-term maintenance therapy in bipolar patients. The problem is that lithium has a lot of potential for side effects. So take a look at the next question in your study guide. Potential side effects include teratogenesis, and we're going to come back to that in a moment, CNS effects like CNS depression, tremor, cognitive dulling. The next bullet is thyroid dysfunction, which can include hypo or hyperthyroidism, and also a euthyroid goiter. It can cause GI side effects like nausea and vomiting, diarrhea, weight gain, and a metallic taste in the mouth, which is kind of easy to remember because lithium is an alkali metal. And then the last bullet is nephrogenic diabetes insipidus. Now we're going to cover diabetes insipidus in the genitourinary videos, but basically lithium makes the kidneys unresponsive to the effects of antidiuretic hormone, or ADH, which means the kidneys can't absorb water and they can't concentrate the urine. So these patients are going to get polyuria, and that leads to polydipsia and thirst. The next question says, what's the treatment for nephrogenic diabetes insipidus that's caused by lithium toxicity? Well, usually the diabetes insipidus will resolve if you stop the lithium. But if you can't stop the lithium because of bipolar disorder, you could treat with hydrochlorothiazide plus amiloride. Hydrochlorothiazide is the treatment for nephrogenic diabetes insipidus in general. And in lithium-induced diabetes insipidus, we add amiloride because it closes the sodium channels in the collecting tubules, which is how lithium enters the collecting tubule cells. We also said that lithium is potentially teratogenic. So if a pregnant woman takes lithium during the first trimester of pregnancy, the fetus may develop something called an Ebstein anomaly. So the next question says, what are the features of an Ebstein anomaly? So the features are the tricuspid leaflets are displaced inferiorly into the right ventricle, there's hypoplasia of the right ventricle, and some tricuspid regurgitation or tricuspid stenosis. And most of these patients have a patent foraminal valley with a right to left shunt. There's also a disorder called cyclothymic disorder, which is a milder form of bipolar disorder, but the symptoms are more chronic. So instead of these big peaks of mania and these deep valleys of major depression, you sort of have mild hypomanic symptoms and mild depressive symptoms that don't quite meet the criteria for true hypomania or for major depression. And to be diagnosed with cyclothymic disorder, you have to have symptoms for at least 2 years. It doesn't have to be continuous. These patients can have periods of normal mood, but those normal periods last less than 2 months. But generally, this is going to be a continuous mood disturbance. So these people have long stretches of hypomania and long stretches of mild depressive symptoms, but they never get severe enough to call it true bipolar disorder. And it's also worth noting that just like with bipolar disorder, cyclothymic disorder does cause significant distress or impairment in social and occupational functioning. We generally treat cyclothymic disorder with mood stabilizing drugs, and they may also benefit from psychotherapy. One other group of psychiatric disorders I want to mention briefly is the dissociative disorders. Now, this has absolutely nothing to do with bipolar disorder, but it really doesn't fit anywhere else in the psych section either. And while these aren't particularly high yield, I do want to make sure you've heard of them. There's dissociative identity disorder, which is formerly known as multiple personality disorder, where the patient exhibits 2 or more distinct identities or personalities. It's more common in women, and it can be associated with sexual abuse. There's something called depersonalization derealization disorder, where the patient has persistent feelings of detachment from their own body or their own thoughts. They feel detached from their body like they're an outside observer watching their life go by. So the name depersonalization is very descriptive. Or they feel like people and things around them aren't real. Everything seems like a dream to them. And then dissociative amnesia is where the patient either has amnesia for a very specific event or a specific series of events, or they could have a more generalized amnesia of their identity and their personal life history. And this may or may not be associated with a dissociative fugue, where they wander off or have some apparently purposeful travel during which they have no idea who they are. They might even assume a new identity while they're gone. It's very rare, but it's very interesting. Think about on Breaking Bad when Walt and Jesse were stuck in the desert for 4 days or whatever, and then Walt pretended to have experienced a fugue state by reappearing naked in the grocery store and pretending he had no memory of the last 4 days. Where was I? Oh yes, time for the end of session quiz. First question, what's the drug of choice in the treatment of bipolar disorder in a patient with renal failure? So lithium is usually the drug of choice, but it's contraindicated in renal failure. So the drugs you're going to use instead would be valproic acid or carbamazepine because they're both metabolized by the liver. Next, what's the most problematic congenital malformation associated with maternal lithium use? It's Ebstein anomaly. And the last question, how long must hypomania symptoms or depressive symptoms be present in order to diagnose cyclothymia? It's 2 years for adults or 1 year for children. And then remember, the patient can be asymptomatic for no more than 2 months at a time during that 2-year stretch. All right, that's it for now. I'll see you next time.